Sandeep Seth, please.
Thank you, Ajay. So I'll straight away go into the talk. Well, we are right now in the midst of a COVID-19 epidemic and a pandemic. As of now, we have a pandemic which is affecting more than 187 countries, more than 98 million people have been affected, more than 2 million deaths. Though we are probably feeling that the pandemic is on the wane, but we cannot be complacent. The case fatality has been about 2.3%, though the fatality has been more in patients who have pre existing cardiovascular disease, rising up to about 10.5%. Our area of interest is the patients who are admitted, where the incidence of heart failure has been almost one fourth. So I'm going to focus on heart failure in these patients. So, what do we know about heart failure in patients with COVID? Most of the cardiologists here and probably otherwise also are seeing more and more patients of heart failure post COVID. If you look at patients who are admitted, this is data from China, patients who were admitted with COVID, almost one fourth of them had clinical manifestations of heart failure. Patients who died, almost half of them had manifestations of heart failure, and almost half of them had evidence of cardiac injury in the form of troponin elevation. So, what happens to the failing heart in COVID? Do we have any data about that? We have some data from patients who died, patients who are autopsied. We also have some data from patients we biopsied or patients who died. I will talk about that. This is a patient who died on ECMO. Looking at the histopathology and the electron microscopy, if you look at the myocytes, you actually find it surprising that the myocytes are actually not damaged. The myocytes are intact. There is very little inflammation in the myocytes. So there is there is no myocyte necrosis. There is very little myocyte inflammation. And in fact, this is the same experience that we have had from two patients that we saw post COVID that come 2 3 months post COVID with severe heart failure. We lost one patient in spite of doing everything, including putting on a heart pump. And then when we looked at the tissue, we found that there were actually the myocytes seemed intact and there was actually no inflammation. And we also found no virus on electron microscopy. The second patient actually recovered. I did an endomyocardial biopsy, but again, surprisingly, the myocytes were intact and there were only scattered lymphocytes. So the experience seems to be similar, that we are not seeing much of myocyte necrosis and much of inflammation in these failing hearts. But there are multiple reports that the virus is actually inside the myocardium. So if you do electron microscopy, you do see the virus inside the heart. So the virus does reach the heart. Another autopsy series, you find that in some patients, the left ventricle is spared. You find that the right ventricle is dilated, probably because the lungs are involved and the lungs cause stress on the right ventricle, causing stress. And again, you find that there is virus inside the myocardium when you do electron microscopy. And you also find that there are elevated biomarkers of with showing cytokine stress, and the biomarker also suggests the BNP is elevated. So this is the picture. There is heart failure. Myocytes seem to be preserved. There are inflammatory markers in the blood suggesting a cytokine storm. But quite often, if you look at the heart tissue, there is very little inflammation in the heart. That seems to be the picture that seems to be evolving. If you look at multiple series of patients who are admitted with severe COVID, again you find that if there is evidence of myocardial injury in the form of troponin elevation, these patients actually do pretty badly. More of these patients are likely to die. Clinical evidence of heart failure seems to vary. There's very little data because most of the initial series echoes were not done. It was all based on clinical series. So the data varies from 4% to 20% of patients with clinical heart failure. Now, what is causing the heart failure? We don't have many mechanistic studies. In fact, we don't really have any mechanistic studies. But if you take lessons from past epidemics of various viral infections, from the influenza and the COVID-1 epidemic, we will find that in those epidemics, there was increased evidence of inflammation, platelet activation, thrombosis, and sympathetic activation. So probably some of these mechanisms are working in causing heart failure. So we probably need to evoke some of these mechanisms. Now, what happens after the patient has recovered from COVID? This is a study done in 100 patients post COVID when an MRI was done to look at what is happening to the heart. So if you look at this study, you find that the ejection fraction in patients post-COVID is slightly less. But if you see, actually, it is slightly less in the normal range. T1 and T2 relaxation, which actually basically reflects the relaxation of the heart, is prolonged. Basically, the heart is slightly stiffer. Troponin levels are still somewhat high. LGE, which denotes fibrosis of the heart, is present in the heart, so the hearts are getting fibrosed. CRP is still elevated, so again, inflammation is still going on in the blood. That means inflammatory markers are still in the heart. Markers of myocardial injury are still in the heart. So there's something wrong still in the body, which is still going on. This is 2-3 months post COVID recovery. So if you look at the various biomarkers and pathways which have been activated in these patients. Now, if you compare patients who have survived versus patients who have not survived, in patients who are non-survivors, markers of thrombosis, markers of cytokine storm in the form of IL-6, ferritin are all elevated. Markers of myocardial injury, that means troponin release, are all activated. LDH is also activated. So there is cardiac injury, there is lymphopenia, there is thrombosis, there is cytokine storm. So all this is happening in these patients. Now, what about virus load and the inflammation? So this is a series of autopsies, 39 autopsies. If you look at this panel, in myocardium where there is no virus versus some virus versus a very heavy load of virus, you find that the degree of inflammation in the blood is very high. As the virus load increases, the inflammation in the blood increases, but it does not correlate with inflammation in the myocardium. So even though the inflammation in the blood is very high, even though the virus does reach the myocardium, it does not correlate with myocardial necrosis. So the myocardium is failing, but it is not failing by necrosis in all patients. Though we have had a single case reports where there is myocardial necrosis also, but it is not the common feature. So this is the panel which shows very clearly if you have COVID infection, there is no COVID infection versus the patients where there was severe viral load, you find that the myocytes are actually very well preserved. So now, how do we synthesize all this together? What is the relationship of COVID and heart failure? Well, these are just possible potential pathways. You have a COVID infection. Possibly you activate the renin-angiotensin system. ACE2 goes down, the angiotensin levels and angiotensin 2 levels go up. This causes vasoconstriction, inflammation, damages the lungs. Along with that, there is a cytokine storm, lots of inflammation going on, causes endothelitis. May or may not cause myocarditis, but at least we are not seeing typical myocarditis that we're used to. Along with that, there is fever, hypoxia, there's a sympathetic activity. Possibly this is a pathway which we have not been able to quantify. There is a lot of oxygen consumption and there is energy expenditure, myocardial oxygen demand. This is a pathway probably we need to measure, and maybe oxidative stress, something which Dr. Kaur also talked about, probably a pathway we need to really measure. And all this causes myocardial damage and leads to heart failure. There may also be pre-existing heart failure which gets worsened. So to summarize, entry of the COVID virus, activation of various immune mechanisms, cellular pathways, humoral pathways, causing a cytokine storm, causing damage to the heart. Manifestations can be varied. We've seen all sorts of manifestations. These patients can present like a coronary syndrome. Patients can come with chest pain. There are florid ECG changes. They look just like a myocardial infarction. We have actually done coronary angiograms and we find the coronaries are normal because we do a ECG. ECG is abnormal. We are not able to do an echo in many of these patients, but troponins are elevated. Take them to the cath lab and you find coronaries are normal. They come with heart failure, which can come at any time. They can come during the COVID episode. They can come anytime up to 3 months. And you find that the heart is failing. And you have to treat them very aggressively in these patients. They can come with heart failure anytime after 3 months also. Again, they may or may not have ECG changes. You actually had patients who presented just with arrhythmias. And later on, you found that there was heart failure. So the manifestations can be just about any kind of. So you have to have a high index of suspicion in this COVID pandemic. You have to look for a history of COVID. You have to test for COVID and You will find that there are markers of inflammation in the blood. You will find markers of myocardial injury. So BNP and troponin will be elevated. You often find IL-6, CRP elevated. Echo, you find there are diffuse LV dysfunction. If you do a MRI, you will find evidence of myocardial edema. You will find evidence of myocardial fibrosis. The care usually is supportive. We have tried to, at least in one patient, we tried to give steroids. We gave immunoglobulins also. Unfortunately, the patient deteriorated within 48 hours before we could do anything. But all sorts of therapies have been tried. Some patients have been saved, some patients could not be saved. So this is basically the way heart failure post-COVID has to be looked for and detected and saved. Thank you very much.
Thank you for a wonderful talk. Any questions, please? Have you seen any incidents of late heart failure? That means a patient who's recovered from COVID and then presenting after, let us say, a few weeks.
Yeah, this patient which I'm talking about, he was actually a student. He had recovered totally from COVID. He came to us at about 3 months, and he came with about 2 weeks of heart failure. He had gone to different hospitals, then he came to us, and he was in florid heart failure. And actually, within 24 hours, he deteriorated very fast. We tried to put an intra-aortic balloon pump. Overnight, he didn't improve. Then we put a Centrimag assist device that also improved him for about 6 hours. Then the Centrimag pump, actually all the tubes just popped out. I mean, his heart was so weak that it didn't even support the tubes. And when we looked at the tissue from there, surprisingly, there was actually no myocyte necrosis. There were no lymphocytes, and we couldn't find a virus. But his blood markers were they were sky high in terms of inflammation. And we had given him everything. We gave him pulse therapy with steroids. We gave him IVIG, and surprisingly, and that's a patient who was almost 3 months post COVID. He had recovered from his COVID properly.
Sandeep, any strategy of monitoring troponins post-COVID will help?
I don't know, because I think now we are going to start trying to look at we can do a series of patients post COVID. I think the simplest thing we should probably be doing is an echo, because most of these patients, their troponins and BNPs are going to be elevated for a long time.
Yeah.
Probably an echo might make a difference. You don't have to look at troponins and BNPs. Echo
Probably
might
we,
be the best.
yeah, probably we may have to
Be
look at
more
the
alert to it.
strain also. Probably we may have to look at the
Yeah,
strain
yeah,
rather than EF
yeah.
to
Strain and
detect
echo
the patient.
probably both have to be looked at.
Yeah.
But you have to be more alert to this.